Hello, I'm here for an interview at the current EHA Congress, which this year is located in Madrid. And I will briefly talk about mantle cell lymphoma in elderly patients. So as every hematologist knows, mantle cell lymphoma is an entity that is more frequently diagnosed in older patients than in younger patients. And due to demographic changes, it is expected that there will be an increase also in the absolute number of elderly patients diagnosed with this disease. We can distinguish between indolent and the classical mantle cell lymphoma. The classical mantle cell lymphoma is the most frequent one, and most of the patients, as I already said, are elderly. So our current standard treatment for these patients is chemoimmunotherapy, followed by a rituximab maintenance treatment. The intensity of the chemotherapy backbone depends a little bit on the fitness of the older patient that one has in front of oneself. So the official standard is R-CHOP as a chemotherapy and the immunotherapy. In more vulnerable patients, one might shift to bendamustine rituximab or include even a bortezomib as a targeted therapy in first-line treatment. And then there are, of course, also milder chemoimmunotherapies, chlorambucil-based, for example. Now, what happened in the last years or so, and is an ongoing process, is that new targeted drugs are introduced specifically to the treatment of older patients with mantle cell lymphoma. There has been some progress in first-line treatment, I would say. For example, there was the introduction of lenalidomide-based treatment, which is then chemotherapy-free when combined with rituximab. This is not approved yet, and we have not a bunch of data, but it is a proof of principle that maybe chemotherapy-free treatment in the frontline setting is possible in older patients with mantle cell lymphoma. But even more pronounced, I would say, is this paradigm shift seen in the relapsed setting. There we have new drugs that are already approved. The main blockbuster here is ibrutinib, and there have been data presented only a few weeks ago at the Lugano meeting showing that using ibrutinib even in a prior line might be beneficial in these patients. And this is, of course, a great advancement. We have also first data combining venetoclax with ibrutinib in mantle cell lymphoma patients that are not eligible for transplant, so older mantle cell lymphoma patients, in fact. So that's a great development currently that hopefully leads us to less toxic therapies, at least that might be equally effective than classical chemoimmunotherapy, or even more effective treatments. And at least in the relapse setting, this has already been achieved. These treatments in that situations are clearly more effective than repeating chemoimmunotherapy, particularly if you have a refractory disease, of course. So one difficult thing in mantle cell lymphoma, though, still is to correctly categorize older patients. So to say whether this is a fit patient or it's a vulnerable patient or even a terminally ill patient is very difficult. And what is completely lacking are really more objective tools to do that. Everybody is talking about geriatric assessment that might be an instrument to facilitate this. However, in mantle cell lymphoma, to my knowledge at least, there are no data on this, and we are still struggling whether we should perform geriatric assessment and in which way, and how we should then judge the results to properly categorize the patients and allocate them to more intensive chemoimmunotherapy, for example, or less intensive one. So this is something that has to be addressed in the future. And some people are claiming that it might not be that important anymore if we have targeted drugs that are less toxic, so that we do not have to stratify these patients. From a genetic point of view, this might only be partially true, because the information that one gets from genetic assessment, namely what genetic impairments does the patient have, are very useful for planning genetic interventions actually. So for example, polypharmacy management, sarcopenia management, physical training, and so on and so forth. So we might reverse genetic impairments by genetic interventions and thereby also increase the overall prognosis of these patients. So this is also another topic that must be addressed in mantle cell lymphoma and in lymphoma in general, of course.